All right, so this is part two. You don't need to look at part one, but if you do, go check out my other video on an article that just dropped this week from the National Academy of Medicine called Anchoring Health Financing on Better Outcomes, System Drivers and Opportunities for Reform. Here's what's interesting about this paper. So in part one, I go through the summary of the system misalignment drivers and the levers that they identify to basically fix this issue. Reminder, the issue is basically we're paying way too much and getting way too little, right? So, we're paying over $15,000 per U.S. citizen per year and getting lower outcomes in a variety of different categories, including just we die earlier. We die earlier than other developed nations that have other types of healthcare systems. So these super smart people, the National Academy of Medicine draws the best of the best, got together, and they're folks from across different sort of spectrums. So folks in finance, folks in healthcare, health tech, etc. Right? Just the folks in the no policy. These folks, and they said, okay, how do we break this down? And that's what makes this paper really good. It is a great breakdown. It's going to be a go-to for me whenever I'm referencing sort of what it is we need to do going forward to make this system make sense. But in sum, the interesting thing is when you just read through it, the entire thing is talking around one thing. Because the only way to meet the goals that the paper sets out in the three categories, health financing, which is one of the system misalignment drivers, coordination and continuity and complexity, right? And then there's 12 associated levers that they identify, and then they go in detail in the paper on sort of recommendations, thoughts they have on how they might tackle this. The entire thing is only doable with a single payer system. I'm not saying that some aspects of this aren't possible in our current setup, but it doesn't take too much to read through the elements and say, oh yeah, this would be possible in a single payer system. And I think implied in there, even though it's not addressed specifically, but single payer and universal coverage. For those of you who are maybe not in this field, right? So single payer means that there is really one administrator of the insurance program, right? So that's what Medicare for All is, for example. It's like Medicare would be the administrator. They would not be necessarily like a Blue Cross anymore kind of a thing. Now, if you get into the weeds, there could still be private payers in that kind of a system, but to keep it simple, that's the idea. One payer, one set of rules. And then universal coverage is the idea that everybody who's a citizen gets access. Or you could possibly design a program, just anybody in the United States, right? But you have some rules around who gets access and how you define universal, the idea. If you take a look at these recommendations, right? So for example, recommendation 1, align all payer payment incentives and global payment approaches. Right now, to do that, you would have to go state by state, get all the payers, all the healthcare companies that operate in that state, that are licensed to work in that state. You have to get them all together and then get all of them to agree on one set of payment incentives and payment strategy approaches. And there are some efforts to try to approximate that now, and some payers are open to that kind of thinking, but remember, these are competitors, and part of what they compete on are their prices and the way they manage their stuff, right? Their administration processes. And so, getting them together in any substantive way is super hard. It feels sometimes impossible. Take the 6th lever that they put, create an effective linked national regional capacity for monitoring and improving health system performance, outcomes, and affordability. So basically, they want to create this dashboard where you have the national regional data to make sure that we're getting the outcomes that we want as a country, right? And so, that's a fine idea, but do you understand how many pots of data you're talking about? Again, state by state, payer by payer. You would have to go through all of these payers in all of these states for the Medicaid data. All that data is just all over the place. And you'd have to figure out a way to get all of these folks together to pool that data so that you'd have that data on a national basis. And then the 10th lever that they identified, improve alignment among public financing programs to harmonize, simplify, and strengthen accessibility, administration, and accountability. Dude, how else are you going to do that if you don't have one payer? Definitely go in, read the paper for yourself if you're interested in health policy or health economics. It's important, it's helpful. I think it's going to be a helpful driver of our thinking going forward. I wouldn't be shocked if it's referenced by candidates in these midterms and in the next set of elections. But in the end, the way to do this is a single payer Medicare for all system. It's the way to do it. The devil in the details around how to do that and what choices we would make. But regardless, it's just interesting. The paper talks around the whole subject. I don't know, let me know what you think.